All right, this lecture is going to focus on GI disorders. This is a very large system with a lot of disorders, so keep in mind we are not covering them all. Utilize your weekly objectives to narrow down what to focus on. Some things that I'm not going to cover include those disorders that are seen in adults and those that are uncommonly dealt with in the inpatient setting. So I'm going to briefly review the structure and function of the GI system and then hit some of the major conditions, and then we will close with some info about TPN, or total parenteral nutrition. I think this should go over 2 presentations worth to get through all of the system disorders. So the primary function of your GI tract is to digest and absorb nutrients to maintain those metabolic processes and support growth and development. So it starts at the mouth and it continues down this pathway to the anus with fecal elimination. And then all along the way, this system aids in digestion and absorption and metabolism of your vital nutrients. Any compromise or abnormality can disrupt this process and lead to issues with exchange of fluids and electrolytes and nutrients, which will then affect growth and development of patients because they are unable to absorb and digest food and their components. So patients with GI dysfunction will often fall on those lower levels of the growth grids, and they may be considered failure to thrive. It's important to remember that the GI system also includes some other organs, such as the liver, the gallbladder, and the pancreas, and they assist in those metabolic processes. The pancreas regulates your blood sugar. It helps digest proteins, which you might recall from learning about cystic fibrosis, that they require those supplemental enzymes to help in that function there. And they also, the one pancreas secretes bicarb to neutralize stomach acid. The liver is essentially a filter that excretes toxins and other biological molecules from the body. So some common effects of GI dysfunction are going to include malabsorption, fluid and electrolyte disturbances, malnutrition, and poor growth. That seems pretty logical so far, right? So here's a category list of the types of disorders that we see in GI. We have malabsorption, obstructive, motility, and inflammatory. So for the sake of everyone's time and sanity, we are going to cover the bolded conditions here. You should be aware of the others. Read about them in ATI, review them in your text. Be sure you're familiar because they might come up on proctored exams, on NCLEX, in your adult questions, because many of these do also show up in adults as well. In fact, you probably are familiar with some of them already. So I'm going to jump right in with short bowel syndrome. This is a malabsorption syndrome that is characterized by chronic diarrhea and chronic malabsorption of nutrients. It is quite literally what it sounds like. The bowel is shortened in length and has less surface area to absorb fluids, electrolytes, and nutrients. This short transit time will increase diarrhea because the stool doesn't have time to bulk up, and this is usually secondary to a loss of actual intestinal length by resection. So maybe the patient had necrotizing enterocolitis in the NICU and the tissue died and needed to be resected, and even some temporary resections like for Hirschsprung's, which we'll talk about in a little bit, can cause this as well. So our focus with these kiddos is on hydration and nutritional support. Often they're getting IV nutrition such as TPN so that we can ensure proper growth and development. So here's some visuals to help understand NEC, as well as gastroschisis, which is another potential cause of short bowel. You can see in NEC how those large areas of the bowel are black and necrosed. This other baby was born with the small intestine protruding out of the abdomen. That's gastroschisis. And so they put this silo over them to allow gravity to lower the intestines back into the abdomen, and then they will eventually go do an abdominal closure. So I want to show this diagram to you, not to have you memorize it, but just to sort of give you some idea of where the absorption happens in the GI tract. The majority of water is absorbed in your small intestine, about 8 to 10 liters per day, whereas the large intestine absorbs only about 1 liter. So you can kind of see how dehydration is a concern in these kids with short bowel. If we look at the vitamins and minerals, we can see how some of these malabsorption issues have significant effects on health. The jejunum absorbs all of those vitamins you can see listed there. And when you have less surface area, you lose more of them on the way out. Also, check out the duodenum, and you can see that iron, chloride, and sulfate are absorbed there. So for those of you who might have had a patient with a J tube or a GJ tube, where they were getting feedings through that J tube, you can see how bypassing that duodenum could put them at greater risk of iron deficiency anemia. So as far as complications, failure to thrive is the most obvious, but because so many of these patients have central lines, sepsis is another really big concern. The GI tract itself is a huge source of microbial seeding of that catheter because the intestine is atrophied, and that can cause an increase in permeability of bacteria. And then they can also eventually just run out of central line sites due to long-term use of TPN. The TPN use over time can also lead to its own issues. You can see the cascade here. It can lead to hepatic dysfunction or TPN-associated cholestasis, or TPNAC. This is just where, after a long time on TPN, with all these gut resections, these children who are dependent on TPN will develop this cholestasis, and this will rapidly progress to a fibrosis, cirrhosis, and portal hypertension combination, usually before 6 months of life. And it happens very rapidly, and it is highly linked with early death. The degree of cholestasis and chance of survival in these infants have been linked to the number of septic episodes that they have had, and it is likely initiated by recurrent bacterial translocation across their gut mucosa. So what we do for these patients to avoid this is we alternate broad-spectrum antibiotics. Generally, this is Bactrim and Flagyl, and you'll usually see they'll be on Bactrim for 4 to 6 weeks, and then they will switch to Flagyl. And so if these patients come into the hospital, it's not because they have an active infection if they're on these medications, it is simply prophylactic. So the ideal goal here is to preserve as much of their bowel as we can during any surgery, and maintain optimal nutritional status, because these patients are often young. And as you might remember, nutrition is really crucial to normal growth and development. Intestinal adaptation is this naturally occurring compensatory process that follows extensive intestinal resection. And so what happens here is structural and functional changes will occur in the intestine that can improve nutrient and fluid absorption in the remnant bowel. So even if these kids aren't tolerating enteral feeds well, we will still give some enteral feeds, we'll call them trophic feeds, to allow this process to occur, because eventually we want to get them off TPN and onto some other enteral feed if we can't do oral. Another way that we can improve absorption is to use median chain triglycerides, or MCT oil. And if they are getting enteral feeds, they should be continuous rather than bolus, because that can lead to dumping. As we give these trophic feeds during recovery, the hope is to rehabilitate that bowel enough that they can tolerate taking in more enteral nutrition, but sometimes that does not occur, and then a transplant will be needed. So now this is kind of cool. If you have a dilated loop of bowel along with your short bowel syndrome, they can lengthen it to try to make up for some of that lost bowel. So they can do a Bianchi procedure or a step procedure. In the Bianchi, they take that dilated bowel and they split it into two, and will create a double length, smaller diameter tube to reconnect to the existing intestine. And then during that step procedure, a row of alternating slits is made along that small intestine, kind of like an accordion, and then they will staple all of those new openings shut, and so it creates this longer and thinner zigzag-like tube that effectively has a whole lot more surface area for absorption. Okay, we're going to move on to pyloric stenosis. This is an obstructive disorder, as most stenosis type conditions are. It is the most common surgical condition in early infancy, and what is happening here is the pyloric sphincter narrows and literally just blocks the exit from the stomach into the duodenum. So as you can imagine, food will build up in the stomach, and eventually it needs to go somewhere. Okay, think about where that might come out. The mouth, right, as vomiting, very forcefully. One of the cardinal symptoms of this is forceful projectile vomiting. We used to joke that it could hit a wall across a room, but it's not always that severe. It can be more mild projectile vomiting and still be pyloric stenosis. This will usually start around a few weeks of age. Parents will say that the child is always hungry, has poor weight gain. There might be a palpable olive-shaped mass in their abdomen. We don't really know what causes pyloric stenosis. Some risk factors include environmental and hereditary factors, as well as prematurity. We also know that oral erythromycin might be linked. Just be aware that this is not the erythromycin ointment that they give at birth, like during your eyes and thighs newborn regimen. This would be oral medication for like pertussis or chlamydia. And Caucasian males are more likely to develop pyloric stenosis than other children. So I mentioned the projectile vomiting and the hunger. It's also important to note these episodes are not occurring with discomfort, okay? In this photo, you can see that smaller mass down on the right side or the lower part of the photo. And then that bigger lump on the left is the peristaltic wave that moves from left to right that can be visible in these patients. I've clinically actually never seen either of these signs, and I don't know if that's because we usually identify this problem before the stenosis gets bad enough to create this mass, or maybe I just was not paying enough attention, but I have not clinically seen either of these things in person. So the diagnosis for pyloric stenosis is pretty easy. We do an ultrasound. The structural issue shows right up, and then we just take that patient into surgery to release that stenosis. Prior to surgery, we're going to do a few things. We're going to make sure that they are NPO, receiving IV fluids, because they're likely pretty dehydrated from the vomiting prior to admission. NG tubes are sometimes used for decompression, but again, not something that I've clinically done before, so that's probably for more severe situations. Post-op is going to involve monitoring for pain and signs of site infection. We usually see scheduled Tylenol every 4 hours for a bit just to stay on top of their pain. We're still monitoring intake and output because that child could still have some episodes of vomiting in the early recovery period due to some swelling. And we will advance their diet as tolerated. Generally, we'll start with Pedialyte a few hours after surgery once those bowel sounds have returned. And we'll start with, a smaller volume and see how they do, and then increase that volume and then advance to formula or breast milk after that. This is a curative procedure. So once that constriction is released, they are good to go. Another obstructive disorder that I'm going to talk about is intussusception, and this is where a segment of the bowel literally telescopes into a more distal segment, which just causes a physical obstruction. It most commonly occurs in kids aged 3 months to about 6 years of age. It's usually idiopathic, but sometimes it can be secondary to hypertrophy of intestinal lymphoid tissue that happens like secondary to a viral infection. So we would discover that just incidentally upon taking a history. It wouldn't change anything in terms of our treatment of the intussusception, however. So these kids will have intermittent crampy abdominal pain because that intestine moves in and out of the telescope. So this looks kind of like a colicky type pain that might be coupled with like a drawing up of the knees into a fetal position. 2 other cardinal signs are red currant jelly-like stool that contains blood and mucus, and a palpable sausage-shaped mass in the upper right quadrant. Now, this is not to be confused with the olive-shaped mass. We have a lot of food going on here in the GI system that we see in that right epigastric area for pyloric stenosis. These kids are different ages, okay? This is also confirmed by ultrasound because it's structural. And so in order to treat it, we can actually reduce the intussusception with a pneumo or hydrostatic enema. So that would be air or water. And then if this isn't successful, they would need to surgically fix the issue. Additionally, if the child comes in with shock due to an intestinal perforation, which is the major complication that we would watch for with intussusception, they will definitely need surgery to go in there and reduce. So I'm going to stop there, and I will continue on with the next video with mobility and inflammatory disorders.